world experiences of first-line maintenance PARP inhibitor treatment in the non-BRCA mutant high-grade serous ovarian cancer population. So just to disclose that my clinical fellowship is partly funded by GSK through the DC Cancer. In terms of background, we know that often high-grade epithelial ovarian cancer is diagnosed at an advanced stage, so often stage 3, stage 4, and this is traditionally associated with poor prognosis and high risk of recurrence. And despite good response to first-line platinum-based chemotherapy, often patients have carboplatin, paclitaxel, most of these patients relapse within 3 years of their primary treatment. The use of PARP inhibitors, however, has changed patient care over the last 10 years, and most patients now who present with stage 3, stage 4 disease will receive a PARP inhibitor. So this just goes through the first-line treatment pathway here in BC. So most patients have surgery, which can be upfront, or they can have interval debulking after some neoadjuvant chemotherapy. Chemotherapy is platinum-based in first line, and normally it's carboplatin paclitaxel. There is the option of adding in bevacizumab. We don't use it very often. In terms of the next thing we do is we have a look for genetic mutations. So we do BRCA testing, a blood test for germline mutations or inherited mutations, and also check within the tumour itself. And based on that, patients are then stratified to go on to olaparib if they have a BRCA mutation, or niraparib if they don't. And this is based on evidence from the PRIMA trial with the patients without the BRCA mutation. We also have available in other places maintenance olaparib and bevacizumab together. It's not available in Canada at this time. So let's talk about the PRIMA trial. This is what I'm comparing a lot of the data to today. So patients were assigned in a 2-to-1 ratio to receive niraparib or placebo once daily for up to 3 years in total. And this was after a response to platinum-based chemotherapy. So these patients had stage 3 disease with visible residual tumour after debulking, inoperable stage 3 disease at the beginning, or any stage 4. So these are patients who are in a poor prognostic group to start off with. And all patients were eligible regardless of having a BRCA mutation or any other mutations in DNA damage repair. The primary outcome of the study was looking at progression-free survival, but it divided it up. So it broke it down to patients who had what we call a homologous recombination deficiency or a mutation in DNA repair, or including BRCA within this population. And then it also looked at the overall population, so all the patients put together. With secondary outcomes, these included overall survival and time to first subsequent therapies, and it also looked at safety data. So we'll talk about these now. So these are the progression-free survival plots for the PRIMA trial. And on the left, to start off with, we've got patients with a mutation. So homologous recombination deficiency, this includes the BRCA population. And we see in this population, patients do very well. And the median progression-free survival is 21.9 months for patients who receive niraparib versus 10.4 on patients who receive it. So a clear benefit in this group. In the overall population, there is still benefit, although we see it's much smaller in terms of benefit gained. And we have to bear in mind that this also includes the patients with the BRCA mutations in this group. However, the patients who do not have a mutation in the homologous recombination pathway or BRCA mutations, the benefit of treatment is actually quite small. However, it was still licensed within this group, and that's why we're able to give it. But you can see that the median progression-free survival is 3 months, so there's a big difference. With any drug that is given, we have to also assess for the safety and the side effects. And this is something to take into consideration if patients are going to have limited benefit. So the most common side effect in this trial shown were anemia and thrombocytopenia and neutropenia. So things related, which could be related to previous treatment, but also to the drug itself. But if you have a look, you see that within any adverse event, 96% of patients on niraparib had an adverse event. So even small things which we might not normally consider as serious are included in this amount. But in terms of grade 3 or more severe reactions, 65% of patients had that. And then we can see at the bottom that anemia of any grade or grade 3, grade 3 anemia is 31%. So that means that patients are often having transfusion and treatment interruptions. With PARP inhibitor trials, it was picked up that there was an increased rate of MDS and AML, and it's something we have to discuss with patients who are starting on the drug. In this population, it was noted to be the same for the niraparib and placebo-treated patients. There's still not a lot known about that and whether it's related to previous chemotherapy treatment on top of the PARP inhibitor itself or the mechanisms of the drug. So how do we apply this to our patients? So most patients now can receive a PARP inhibitor if they have advanced ovarian cancer. We have a very different demographic to the clinical trial cohort. So we have patients who are more complex, have other medical conditions, lots of polypharmacy, and we also have patients who are less fit. We know that from looking at the trial data, some patients will benefit, but some patients will not. And we have to weigh that up against the risk of the drug toxicity, which in some cases can be severe. And this is all part of the challenges in clinical decision making that we have to make in oncology. So I've broken my project up into 2 parts here, but the first thing I'm going to talk about is the real world benefits of first-line niraparib in the non-BRCA mutant population. We'll come to the other bit a little bit later on. So the inclusion criteria was patients with non-germline and non-somatic BRCA mutant or HRD unknown status, high-grade serous ovarian cancer. We also can include the endometrioid subtype, however, this is a lot more rare. In terms of testing, patients will want to have a blood test and they also have tumour testing. And we only included patients who had proof of both. So the way that we found the data was through the regional electronic patient records, so going through Cerner and looking at things from other centres. I looked at patient demographics, the treatment records, and we also looked at progression-free survival, which is defined here as the start of niraparib to radiological CT evidence of disease progression. And I also had a little look at the next line of therapy and response if this was available. So in terms of patient demographics, 96 patients met the inclusion criteria and they received systemic therapy from these sites. So most patients received treatment in Vancouver, but we also have some from other parts of the region. The mean age of patients at diagnosis was 67 years, although there was quite a big range from 41 to 86. And a lot of patients were age 65 years or older, which is classed as elderly in terms of oncology treatment. We can see that most patients had late-stage disease, being 3C or stage 4. I've also put a graph on just showing the form status documentation. You can see that patients in clinical trial are often form status 1 and 2, 0 to 1, and here we've got 2 to 3. We have to take into account that this is at the start of their presentation with chemotherapy, and patients might be more symptomatic from their cancer. So, but this may have improved quite a lot when they start their PARP inhibitors. However, it can often be difficult from patient records to gain data at this time. So first of all, we'll talk about the timing of surgery. So 71% of patients underwent interval debulking surgery. This is actually quite high. 21 patients underwent primary surgery and 7 patients didn't have any surgery at all. So they had chemotherapy and then went on to niraparib. And that can be based on patient fitness factors, patient choice, or a decision made by the surgical team that patient's not fit to go ahead. And in terms of outcomes, what happens is that when the surgeons provide the report, they say, was there any disease left during the operation? And 12 patients were documented as having a complete cytoreduction, so there's no visible disease. 57 patients, so 59%, with an optimal cytoreduction, and that means less than 1 centimetre of visible disease after surgery. And suboptimal means more than 1 centimetre. So in terms of how these patients do, we know that people with a suboptimal debulking at this stage will do worse. In terms of chemotherapy, all patients received at least 6 cycles of platinum-based treatment prior to receiving a PARP inhibitor. 6 cycles tends to be the standard of care and what's often used in clinical studies. But there's a lot of variation between clinical sites here. And as we can see, some patients went on to have 9, 10, 11 cycles. Sometimes this is, going back through the notes, this was because the patient wasn't having surgery and they were given as much chemotherapy as they could tolerate. But there's something to take into account is that later down the line, this could lead to further toxicity, particularly hematological causes. So it's something that we have to be aware of now we're using the PARP inhibitors more often. For neoadjuvant patients, the mean number of cycles prior to having surgery was 4. Let's talk about niraparib. So in terms of the dosing, the maximum dose given is 300 milligrams once daily. And that was initially the starting dose. However, during the NOVA trial, which was performed in platinum-sensitive patients in recurrent disease, a lot of them were experiencing toxicity. And it was decided to have a look for factors that could be identified that were putting people at risk. So baseline platelet count of less than 150 and body weight less than 77 kilograms was listed as higher risk of patients developing grade 3 or higher thrombocytopenia. And that means that patients would have to stop the drug, have a lot of interruptions, potentially have transfusions, hospital admissions. So that's what we're keen to avoid. And based on that, an individualized starting dose is recommended. And that's for patients with weight less than 77 kilos or a baseline platelet count of less than 150 are recommended to start at 200 daily. So the individualized starting dose was used in 60% of patients in total, and the weight of less than 77 kilograms was the most common reason. A lot of patients are actually started on niraparib 100 milligrams daily, and sometimes it isn't documented why. However, it tends to be in patients who are a little bit more frail or patients who have experienced toxicity during their chemotherapy. It's something that we need to look at a little bit more, but patients are starting on a lower dose than recommendation. But actually, most patients actually have a dose reduction, and the final treatment dose of 100 milligrams was in 67%. So 2/3 of patients finished up on 100 milligrams. And only a third of patients didn't undergo a dose modification. So in the trials, I think it was over 70% had a dose reduction, and we can still say that in our real world population, we're still needing to modify the dose. In terms of time to treatment, it's recommended that patients start treatment within 12 weeks of their final chemotherapy cycle. So within our population, 89% started within 12 weeks, and there were some delays. And when I looked into this, there were some factors involving patient fitness after surgery, patients deciding whether to take it. There was a little bit of crossover when it was on the compassionate access program and people were waiting for things to be set up. And there was also some patients that through reasons such as Cerner and appointments being not booked in time or promptly that they missed out, but were decided to be put on the drug a little bit later than recommended. In terms of monitoring, we know patients are high risk of side effects in the first few weeks of treatment, and therefore we monitor them closely when they start the drug. The recommendation is to have a CBC weekly for the first 4 weeks. This is the time when anemia and thrombocytopenia are most likely to occur. Patients are also recommended to have the blood pressure checked weekly for the first 8 weeks, as hypertension is a common side effect. And if we think of our patient population, a little bit older, lots of other medications, they're at high risk of worsening hypertension if they already have a pre-existing condition. So it's something to be careful of, and particularly with thrombocytopenia as well, we want to avoid high blood pressure. Patients can normally restart medication when they've had an antihypertensive medication initially. But we monitor the blood pressure for the first 8 weeks, and patients have home monitors to do this, or they can have it done at a local pharmacy if they're not able to manage this. If patients are stable and things are okay, then we move on to 4 weekly monitoring. And often they go into our nurse-led clinics at BC Cancer when they're stable and just touch base with the doctors in clinic every so often if everything's going to be okay. If patients have dose reductions and changes, then we need to monitor them a little bit more closely, and that can lead to more visits and more blood tests. So during the first 3 months, the way that I've got this is quite diverse because of the patient groups. So what I did is I looked at the mean number of routine clinical appointments, and this came as 4. This varies quite a lot between treatment centres. So some people do the blood test but don't necessarily have an appointment with the patient. So they will just keep an eye on the labs from distance. Some people check in with them every 4 weeks, some people check in every 2 weeks. I've also looked at the mean number of extra clinical encounters. This includes ER admissions and telephone calls to the triage line, or appointments with family doctors which are documented where people have had complications because of the treatment. And we can see there's a big range there. So some people manage very well and don't have any side effects, but it could be that some people need a lot more input from the clinical team. And there we go. We look at the number of lab tests as well. This is often done on a separate hospital visit to attending the clinics. So the mean number of lab draws came as 6, which was a surprise because we have 4 up front in the first month and then 2 extras. That's probably the number that's recommended if there's no complications. But again, you can see there's a big range involved in this. And one person had 14. So that's a lot of extra time, hospital visits or clinic visits to have blood taken. In terms of the mean number of extra lab draws, we can also see that some patients who have complications have many additional blood tests on top of it. This is also something to take into account in a patient population where we're not sure of benefit. And so obviously that will come out in time based on patient response. But if you're putting people through a lot of hospital visits and lab tests, it's something to bear in mind because it's an extra burden on the patient and also on the services. So 57% of our patients required at least 1 dose reduction. Some of them went up and down. So they might have started on 100 and then gone up to 200 and then got back down again. Most patients tolerated 100 better. The most common reasons for dose reductions were thrombocytopenia, so a reduction in platelet levels, fatigue, and nausea. And they weren't necessarily at a high grade, but it was intolerable for the patient at home and they were struggling to manage. Hypertension led to a dose reduction in 7 of our patients and insomnia in 5 patients. So again, something that we often don't check on in clinic, but can affect quality of life quite significantly. I also noted that tachycardia is a common thing that patients report, and 25 patients in total reported this from the notes. It's not actually recorded in the PRIMA trial. So there's a table which documents any side effect affecting more than 20%, but I can't find anything about it in the supplementary information. But it's interesting to see that. And is that related to something that we look into a little bit more detail? Is it because we've seen more patients over time? Is it because patients have other conditions such as heart disease, hypertension, anxiety, other things which are leading to cardio? But it's all things which, even if they're minor side effects to us and to a clinical trial, are things that patients are experiencing.
Also, Nicola, if you want to say, Niraparib is the only target that causes hypertension. No other drug in that class does that, so it has some off-target effects.
The doctor is just saying that.
I don't know why that is, but we all think tachycardia is related.
The doctor is just saying that the Niraparib is the only PARP inhibitor which causes hypertension. We don't see it in other drugs that we use, such as olaparib. In terms of grade 3, adverse events are more severe. Thrombocytopenia is the most common, and we do see that in the clinic quite frequently, and that's why we keep a close eye on the labs in the first few weeks. 7 patients stopped treatment due to toxicity despite a dose adjustment, and this looked like it was lower than the PRIMA trial, but I actually think it's higher, and I want to go over this data again because I classed the patients who had a discussion with their consultant and stopped and may not have gone back on with a dose adjustment as a separate category. So I think the rate of the patients stopping due to toxicity is probably a little bit higher. In terms of the duration of treatment, it's recommended for up to 3 years in total until progressive disease or unacceptable toxicity. So this is still quite early. So the median length of follow-up for patients that I have is 22 months. And the median number of cycles is 11, but we've got a big range involved. For one, it means that the patient stopped quite soon and they didn't tolerate the drug very well. In terms of 39, these are patients which had come to the end of their 3-year treatment. In total, 57% have now progressed on niraparib, and 5 patients stopped early and then subsequently progressed. So this is the median progression-free survival for our patient cohort, so from the start of niraparib to evidence of radiological progression. And this came as 10.8 months. And how does this compare to the PRIMA study? So for the overall population, it came as 13.8 months with niraparib and 8.2 months with placebo. Obviously, we don't have a placebo group involved here. And we have to take into account that within the PRIMA study, in the overall population, this is patients including the BRCA mutations. So these are the patients which do better, and it's pooling all of the groups together. I've got some data on the next line of treatment, and this is, the numbers are relatively small, and there's a lot of diversity with treatment options which have been. But I'll come back to what I was talking about. So the next line of treatment, there's a lot of variability, and again, this is dependent on patient, dependent on site. We can see that this patient group have relapsed within 6 months of platinum, and so this group of patients have a poor prognosis. Quite a lot of them were given carboplatin actually, and I think some of them were given benefit of doubt that it's around the 6-month mark that they relapsed, but some were given earlier. If we have a look here, most of the patients, although small numbers, are not responding very well. So we've got partial response, stable disease, aggressive disease, and not applicable if they're not have further imaging or if it's too early to see a response yet. But we can see most of these patients are doing poorly. And then I've also looked at the patients with a higher platinum-free interval, and these patients tend to have a better prognosis clinically. Again, a lot of different treatment options were selected. I've just highlighted here, again, numbers are very small, but patients in this group are doing a little bit better, and particularly with combination treatment with platinum, with the challenge, and then we tend to give liposomal doxorubicin. But there's also patients in this group who it's too early to have a look at a response yet. So they've not yet had a CT scan and they've only just relapsed. These patients are taking a longer time to have a relapse. In terms of overall survival, so again, I've had a little look at this, and about 30% of patients have died within our group, with a median overall survival of 30 months. And the PRIMA initial paper, the way that they looked at it was probability of survival at 24 months. So I've worked that out for our group, which comes out as 88% versus 84% in the PRIMA trial. So just to summarize where we're up to at the moment in the real world data, despite the use of an individualized starting dose, many patients still require dose reductions of niraparib due to toxicity. So that might be things such as hematological side effects, such as thrombocytopenia, but also the lower level things which are preventing people from living their normal day-to-day life. Tachycardia appears to be a more commonly reported toxicity compared to seen in the PRIMA trial. But there's variation in practice across a lot of sites. So patients have different numbers of chemotherapy, different numbers of blood tests. Recently, we should look at to try and standardize that a little bit better. In terms of the median progression-free survival, it's lower in our group compared to the PRIMA trial, but that could also be related to the fact that we have the patients without the BRCA mutations or the known HRD mutation. But how can we better select patients for niraparib therapy? So the next bit I had a look at was, and I'll come to HRD testing shortly. So the next bit is to look at potential surrogate markers of niraparib response. So I've had a look at the Keelan score, and I've had a look at the chemotherapy pathological response score. So in terms of best markers of PARP inhibitor response, we know that BRCA1, BRCA2 mutations are the best indicator for this. But there's also a number of other mutations which are recognized within the DNA damage response pathways, such as RAD51C, which is a common one, which is associated with drug response. It's difficult because when you have major pathways, and during my PhD, you can see that if you hit a major target, there's often a resistance pathway which upregulates to get past it. So there's not many things such as PARP which you can target. The other thing we can look at is a functional assessment. So that's looking at CA125, which is the tumour marker we look at in ovarian cancer, CT imaging to look for response, and also healing score. So we'll just go into a little bit about what HRD testing is, and it's determined by a custom hybridization assay, and these are commercial tests, and they're all a little bit different. The test itself is performed on tumour tissue, and the most common assay used in clinical trials is through a company called Myriad MyChoice test, and this is the one that was used in PRIMA. And the way that they calculate this is through looking at lots of different aspects. It's like a historical scar within the tumour tissue. So they look at loss of heterozygosity, and they look at imbalance and large-scale state transitions. They also look at other aspects within BRCA. So they look at methylations, they look at other types of mutation which are not normally considered. And then they work out a score based on all of the changes seen within the tumour tissue. And a score which is greater than or equal to 42 is considered to be HR deficient. So that's what we're referring to within our groups with patients who don't have a BRCA mutation necessarily, but might have another mutation within DNA damage repair. But this assay is not publicly funded by the health system within Canada. It's expensive. So I think the commercial price of it is $5,500 per sample. And it gets sent to an external lab, and it takes some time to come back. So there's lots of factors involved with that. I've put a star there because it is currently accessible through GSK, so we've got some compassionate access to it. Patients have to sign a consent form in order for this to happen because it goes through a private company. But if people want to know more about it, then they can ask our clinical team, because it's something that we've started to do, send off samples. Next thing we're going to talk about is the healing score. And what this is it's a mathematical model which looks at the elimination of CA125, so the tumour marker that we monitor in patients with ovarian cancer. And there's two different models. So there's one that you use for patients undergoing neoadjuvant treatment, and there's also a separate one for patients having adjuvant treatment. A different model. I don't know the ins and outs of the math behind it. But in terms of, there's a website which is validated and people are using in trials. And what happens is you put in at least 3 consecutive CA125 values in the first 100 days of treatment. And that calculates a score. Fortunately, it's come up a little bit small on the screen, but a favourable score is greater or equal to 1. This is an example of a patient record. There's lots of use of healing now, so it's been used to have a look at chemosensitivity, because the higher the rate of excretion of CA125, the better response to initial chemotherapy. There's also been some look at in other treatments. So there has been some look in PARP inhibitors, but this has been more in later line studies, and it's not been looked at in the rapid. So I had a look at the progression-free survival based on the Keenan score, and this is with all patients included. So 79 patients in total had a valuable Keenan score. So that's the at least three CA125 values within the first 100 days of chemotherapy. You can't use the one at diagnosis. It's got to be the one after cycle 1, and then values beyond that. But progression-free survival, we can see, has been significantly better in patients with a score greater or equal to 1 compared to the patients with a lower score. And the median progression-free survival in our population was 433 days versus 200 days. So this initially, the gap was a lot smaller. But as I've gone back and reevaluated, and we can see that patients are in a better prognosis group are living longer, we're starting to see a bigger difference between the two. And then I also had a look at the patients who have undergone neoadjuvant chemotherapy. And we often follow CA125 as prior to the CT scan to assess response. And we can kind of see, okay, patients are clinically improving, their CA125 is coming down, they're responding well to the chemotherapy. And again, we get the same trend. So patients who have a Keelan score which is higher have a trend to longer median progression-free survival. So again, this is only small numbers, but we're seeing a nice pattern and a trend here which fits in with other studies and other treatments, and this is beyond the initial platinum chemotherapy. I also had a look at chemotherapy response score. This is the histopathological grading system for assessing neoadjuvant response. So tumour sent off to pathology, and there's a 3-tier score based on the mental assessment of residual disease at the time of surgery in patients who've previously had chemotherapy. So in CRS1, there's very little response to chemotherapy, and CRS3, there's a complete or near complete response, and 2's in the middle. But based on it, patients have to have evidence of a mental disease to be able to do this, and if they've had a really good response, often they can't be scored because there's no remaining disease. So it's another thing that we do check regularly within the clinic. Let's have a look to see whether there is any trend. And 55% of our patients, and 53 in total, had an invaluable CRS, but we didn't see any difference in progression-free survival within this. So based on what we've just had a look at, and these are very exploratory, but progression-free survival was significantly longer in patients with a Keelan score greater or equal to 1 compared to less than 1, although the numbers acknowledged in this study are small. But it could potentially be a useful tool to predict PARP inhibitor response in patients where HRD testing is unfunded. And we have to think in the greater scheme of things, if it's costing a lot of money, it's looking at saving resources, and is it accessible to other places if it's with less, so sort of countries with less wealth. So is this something that could be done as an affordable alternative? I've done some, I've had some abstracts published based on this and a poster at a recent meeting. And this is a further update of the data moving forward. And as we're going through, we're seeing more benefit with the healing. So in terms of future plans, we want to do retrospective HRD testing on the tumour samples of our patients who we have the Keelan scores for, to see if the HRD score correlates. We'd be interested to see if the patients with the higher scores are HRD deficient. And we've made an application for funding for this. Obviously, it's very expensive, but hopefully we can get some research cost reduction based on that rather than the commercial assay. Ideally, we need to increase patient numbers. I've asked for further for a greater time frame to be able to do this, but unfortunately things have been relatively slow. There's also been difficulty in we've not been able to get data from the initial patients on the Passion Access Programme, and that's because the data is held by Bayshore and they won't hand it over to us for privacy reasons. That's something to bear in mind in future studies and projects that we do, that sometimes you can't access the data on the patient because it's given from an outside company. So we'll end at that point. I'd just like to say thank you to the clinical team. And I'd like to say thank you to Steph, who's from UBC. She's a medical student who helped do a lot of the initial data collection and been involved in the analysis. I'd just like to thank all colleagues here. This picture is actually my hometown. I'm due to return to the UK shortly. And I just thought I'd show you what I'm going back to. It definitely won't be like that in February though. And thank you very much for everyone who supported me while I've been here.